Hello friends. So there is always 2 to 5 questions from the trauma, any examination, be it NEET PG, NEET SS or FMG, okay, or even it is very practical knowledge. So what I have chosen, I will discuss ATLS, all the important points, okay. So the currently 10th edition ATLS is going on, okay. So there are 12 chapter of ATLS, okay. So starting with chapter 1, all the important points I will discuss, okay. So 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 the primary and secondary survey are repeated frequently to identify any change in patient status, okay. So primary and secondary survey are repeated frequently, okay. It's not like one time, okay. So one knowledge, okay. Then so what is the use of ATLS? So ATLS principle guide the assessment and resuscitation of injured patient, okay. Then in pre-hospital system, what are the things that pre-hospital system has to be done? So notify the receiving hospital, then airway maintenance, control of external bleeding, shock, immobilization of the patient and immediate transport. That are the work has to be done in pre-hospital system. Okay. Okay. So now when the patient reach the hospital, we have to do the triage. So what is triage? Triage means sorting of the patient based on the resource required for the treatment and resource available, okay. So there are two terms which is asked: what is multiple casualty, what is mass casualty. So in multiple casualty, number of the patient and the severity of the injured not exceed the capability of the facility. So it is under the capability of the facility, okay. In mass casualty, number of the patient and severity of the injury does exceed the capability of the hospital staff. So in mass casualty it is exceed, in multiple casualty does not exceed with the capability of the hospital, okay. So in primary survey there is a B C D E. So this is very classical question. What are the full form? A for airway maintenance with restriction of cervical spine motion, then B for breathing and ventilation, C for circulation with hemorrhage control, D for disability, that is assessment of neurological status, and E for exposure or environment control. So this clinician can quickly assess ABCD in trauma patient in 10-second assessment. So this can be asked. So for ABCD, how much time needed is 10 seconds, okay. So by asking the patient name and what was happened, so if there is an appropriate response, so what we can assess, there is no major airway compromise, that is ability to speak clearly, then breathing not severely compromised, so that he can ability to generate air movement, okay, and level of consciousness also be assessed, if he can describe the event, okay. So first priority is airway management. So in airway management we can do clearing the airway, suctioning, administration of oxygen, and opening and securing the airway, okay. So this is very important line. If GCS score is less than 8 or less than 8, so we have to place a definitive airway, that is cuffed secure tube in the trachea. So the number is important, GCS is 8 or less, so you have to definitive airway. What kind of definitive airway? Cuffed, not, this is asked very many times, cuffed, okay, this is cuffed, okay. 8 and cuffed are important point, 8 and cuffed, okay. So a definitive airway should be done if there is any doubt about the patient ability to maintain airway integrity. Okay. A simple pneumothorax can be converted to tension pneumothorax when patient is intubated and positive pressure ventilation is started before decompressing the pneumothorax with chest tube. So this can be asked in a clinical scenario question. So just highlighted this one. Okay. So hemorrhage is a predominant cause of preventable death after injury. This is asked many times. So what is the most common cause of death in injury? Hemorrhage. So regarding the pulse, the central pulse, that is femoral and carotid artery, palpated bilaterally for quality, rate and regularity. Absent of central pulse, need for immediate resuscitative action. Okay. So in central pulse, we should look for quality, rate and integrity. Rate is also part of the central. Okay. So if any external hemorrhage is present, it is managed in primary survey only. How? By putting the direct manual pressure. Okay. If the manual pressure does not work, use a tourniquet only when direct pressure does not affect. Okay. And patient life is in danger, threatened. Okay. It should not be blind clamping. Blind clamping should not be done. Now definitive bleeding control is essential along with appropriate placement of intravascular volume. Okay. So two large bore peripheral venous catheter are placed. So large bore and short venous. Okay. Here is not mentioned, but in Bailey it is mentioned. So large and short cannula. Okay. And we take the blood sample from that same IV cannula, and that sample is sent for baseline hematological studies including pregnancy test, blood type and cross matching. We can also go for blood gas and lactate level. Okay. Aggressive and continued volume resuscitation is not a substitute for definitive control of hemorrhage. Okay. So you have to control the bleeding. Just a resuscitation will not help the patient to manage bleeding. Okay. And when we give IV solution, it should be warm. The temperature should be in between 37 to 40 or degrees Celsius, or in Fahrenheit it will be 98.6 to 104. This is, you can remember our normal temperature to high grade fever, 98.6 to 104 or 37 to 40. Okay. And how much fluid should be given as a bolus? 1 liter. This can be asked. Okay. 1 liter of isotonic solution. Okay. If the patient is unresponsive to initial crystalloid therapy, then better to go for blood transfusion. Okay. And in trauma patient, tranexamic acid administered within 3 hours of injury in field only. Okay. And when patient reach the hospital, it should be given infusion over 8 hours. Okay. So 3 hours in Tranexa, it is 3 hours and 8 hours. Input within 3 hours and infusion over 8 hours. In disability, that is D for disability and neurological evaluation, we look for the consciousness and pupillary size and reaction. Also for spinal cord injury level, we look. Okay. And if they are specific regarding the temperature of the IV fluid, so it is more 39 and 102.2, 39 and 102. Okay. So there can be, they ask what is, when you will see the pulseless electrical activity. Okay. So example are cardiac tamponade, tension pneumothorax. This you can remember. The third one is profound hypovolemia. Okay. So profound hypovolemia. Okay. So pulseless electrical activity seen in cardiac tamponade, tension pneumothorax, and profound hypovolemia. Okay. So bit about pulse oximeter. So we can apply in finger, toe, and ear lobe. So this can be asked. Ear lobe also is a site. So how it work? The relative absorption of light by oxyhemoglobin and deoxyhemoglobin. So what it cannot measure, it does not measure the partial pressure of oxygen or carbon dioxide. Okay. So regarding the ventilation, we can go for ventilation by monitoring the in-tidal carbon dioxide level. The important one is capnography. So what is the use of capnography? Capnography confirm the intubation. Okay. So intubation. So it is in airway or esophagus. Just. So capnography does not confirm the proper position of the tube within trachea. So it will just say your tube is in trachea, not where it is. Okay. So it is just differentiate between esophagus and trachea. That's it. Okay. Okay. So placement of urinary and gastric catheter can be done during primary survey or following the primary survey. So they can ask can be done during also. Okay. During the primary survey you can put catheter and gastric catheters. Okay. Okay. So monitoring of urine output is best by putting the catheter, bladder catheter. Okay. This is also been asked. Okay. So it is contraindicated when you suspect the urethral injury. And how you will suspect urethral injury? When the blood is present at urethral meatus or perineal ecchymosis. Okay. So in that case you will do retrograde ureterogram. Okay. Okay. Regarding gastric catheter, what is the use of putting gastric catheter? So it will decompress the stomach, decrease the chance of aspiration, and check any upper GI hemorrhage from the trauma. Okay. So if you suspect the fracture of cubiform plate, so put gastric tube orally, not nasally. Okay. Because you have to prevent intracranial passage. If you put nasally, it may go to intracranial. So in cribriform plate, you have to put oral gastric tube. So in trauma, you have to do AP chest and AP pelvic, not PA view. It is AP. Okay. So now come to secondary survey. Secondary survey only begins when you have completed the primary survey, that is ABCDE. Okay. And what is secondary survey? It is head to toe evaluation. Secondary survey is head to toe evaluation. Okay. So this is very important. Ample history. So ample history is a part of secondary survey. Important line. Okay. So what is the full form of ample? A for allergy, M for medication, P for past illness and pregnancy, and L for last meal, E for event or environment. Okay. So this is very important. Ample history. So fracture of midface can be related to cubiform plate injury. So midface, you may confuse with upper lower face, but it is a midface can cause cubiform plate injury. Okay. Okay. Then so major causes of cervical vascular injury caused by penetrating injury. Okay. Okay. So we will read in subsequent chapter about cardiac tamponade and pneumothorax, how to differentiate, but bit of point like distant heart sound and decreased pulse pressure seen with cardiac tamponade. Okay. In addition, cardiac tamponade and tension pneumothorax both can have distended neck veins. So cardiac tamponade and tension pneumothorax have distended neck veins, but in cardiac tamponade you will get distant heart sound and pulse pressure. You just remember now the pulse and heart sound related to heart. So in cardiac tamponade you will get both two. Okay. and hypovolemia can minimize or eliminate this finding. Okay. So or in tension pneumothorax, while percussion you will get hyperresonance. Okay, and chest X-ray or E-fast can can tell you hemothorax or simple pneumothorax. Okay. So in when you see the ecchymosis over iliac wings, pubis, labia or scrotum, you can suspect pelvic fracture. Okay. And regarding vaginal examination, it is only performed in patients who are at risk of vaginal injury. It is not routinely performed all the female patients. Okay, remember that. Okay. So in trauma patient, what is the adequate urine output? So in adult and pediatric, in adult it is 0.5 ml per kg per hour, and in pediatric it is 1 ml per kg per hour. Pediatric means older than 1 year of age. Okay, so in adult 0.5 ml, pediatric 1 ml. Okay, regarding analgesia, we can go for opioid or anxiolytics. Avoid IM injection. Okay. There is also, when you receive any patient in hospital, you have to follow the MIST. What is MIST? MIST for mechanism and time of injury, then injury found and suspected, S for symptom and sign, T for treatment. But ample is more important than MIST. Remember that. Ample has been asked many times. So MIST, mechanism, I for injury, S for symptom, T for treatment. Okay, so we'll revise the quickly important points. Okay. Just the important ones. Okay. So multiple casualty, mass casualty. In multiple casualty, the number of the patient and severity not exceed the capability of the facility. In mass casualty, it does exceed the capability of the hospital. Okay. Then ABCD, you all know. Okay. Then I will emphasize this point. GCS score 8 or less, it needs definitive airway. That it comes as a cuffed tube. Okay, cuffed tube. Okay. Then hemorrhage is most common cause of preventable death after injury. Important point. So any external injury, hemorrhage, you have to first control by direct manual pressure. This line has been asked many times. Okay, if cannot manage by manual pressure, go for tourniquet. Okay. Then in blood sample, you have to send all the baseline study, pregnancy test, blood type, cross matching, blood gas and lactate level. This much. Okay. The temperature of IV fluid should be 37 to 40 degrees centigrade or 98.6 to 104. How much bolus fluid should be given? It is 1 liter and isotonic. Okay. If not responding, then blood transfusion. Tranexamic acid should be administered within 3 hours of injury in pre-hospital setting, and when the patient reaches the hospital, it is given as an infusion over 8 hours. Okay. Pulseless electrical activity seen in cardiac tamponade, tension pneumothorax and profound hypovolemia. Okay. Capnography will tell you your tube is in trachea. Okay, so it can differentiate between esophageal or tracheal intubation. Okay, just that. Okay. And then urinary catheter is contraindicated when you suspect urethral injury. So that is blood at urethral meatus or perineal ecchymosis. In that case, you will do retrograde urethrogram. Gastric catheter prevent decrease the risk of aspiration, and it is given per orally in when you suspect cubiform plate injury. Okay. So you will do AP, all the anteroposterior X-ray, either chest X-ray or pelvic. Okay. In secondary survey, there is a very important line, that is ample history. A for allergy, M for medication, P for past illness or pregnancy, L for last meal, and event or environment. So ample history is a part of secondary survey. Okay. And we'll discuss in the next subsequent chapter. Okay, urinary output, many times asked. In adult it should be 0.5 ml per kg per hour. In pediatric it is 1 ml per kg per hour. Okay, then the last missed is mechanism of injury, mechanism and time, then injury found and suspected, symptom and sign, and T for treatment. Okay, thank you.